We are very, very excited to have Dr. Jenq with us. She has done amazing work at Michigan Medicine on a lot of different issues. Is my personal go-to for all my geriatric questions about my parents. Thank you. Knew that was going to get you. Yes. And we're just going to start, Grace. Just get us back in line.
Okay.
Just get us in
Let me
line.
get you guys back in line. Hi, thanks for coming on a 4:30 afternoon class. Impressive that you guys are all here. So I'll just tell you a little bit about myself. So I was an undergrad at Yale, and I did a molecular biophysics biochemistry degree. And I know it sounds really crazy, but to be honest, I probably should have gotten a degree through CHEPS because that is far more interesting. So back as an undergrad, I was really interested at the cellular level or the molecular level, processes and systems. But then over time, I became a geriatrician. So I went through medical school, internal medicine residency, and then I did a geriatrics fellowship. And I found myself really liking complex patients. Geriatric patients are incredibly complex. And I like complex systems, which is healthcare. And so you guys are all very much aware of how challenging our healthcare system is, and especially when you have a sick older adult in a very, very complex healthcare system. There's lots of room for change and opportunity. So I really do enjoy trying to take care of older patients in their home because I think that's one of the best places an older person can be rather than in a very chaotic, discombobulated healthcare environment. So I do a lot of things in the home. I've done hospital care at home where we take nurses and doctors and all the treatments that you get in a hospital and bring it to the home. But I also do just regular visits in the home to understand what is improving their health and what is not improving their health. And I'm also very interested in that transition between brick and mortar hospital and the home setting. So I don't know if you guys got all the slides beforehand or not. No? Okay. So what we're going to talk about today, and I really want you guys to brainstorm, are, what are the factors that contribute to the overload of medications, specialist visits, and fragmented care in the older adult. And so there are lots of different things that go into this equation, and you can see them here. But I would love you guys to just take a guess. So when I'm talking about older adults, I'm saying people who are age 65 and older. Okay, so they're like Medicare patients. What percentage of people over the age of 65 have 2 or more chronic diseases?
All.
Close, 70%. So close to 70% have multiple chronic illnesses, okay? And when you have multiple illnesses, you end up with multiple doctors, right? And so I was actually able to look up in a recent article in Annals of Internal Medicine that the proportion of Medicare patients seeing 5 or more doctors annually increased from 17% to 30% in the last 20 years. So 1 out of 3 persons over the age of 65 has 5 doctors. And guess what? Each of those 5 doctors loves to see their patients at least 2 to 3 times a year. Okay, that's just how it is. Return to see me in 3 to 4 months. And so you can imagine that each beneficiary is seeing 5 doctors 3 times a year. That's 15 visits. That's almost once a month or maybe even more. And so when you have that many specialists involved, you think that they're all talking to each other or everybody's on the same page, but they're not. Because specialists, like cardiologists, think about what happens with the heart. The kidney doctors only think about what's happening with the kidney. And the way that our healthcare system is set up is that when you go see a doctor for the first time, you usually get about like 40 minutes to see the patient. And then you have about 20 minutes to write your note really fast. And then if you come back to see that doctor, you have 20 minutes to interact with that doctor. And you have 10 minutes to do your notes. And so I can guarantee you that in 20 minutes for these older individuals, they're just putting out fires. You're just saying, okay, are you on an aspirin every day? Did you have any chest pain? Are you having a heart attack? They're not looking to see, oh, what did the other 4 specialists do in the meantime? Okay, so there is a lack of communication between providers. We try our best, but I can guarantee you if you talk to your parents or your aunts and uncles and grandparents, you will hear this horrible story of none of my doctors know what's going on, no one's coordinating anything. And it is kind of one of these issues that we have a silver tsunami of patients just like this coming through. And our healthcare system, along with our electronic medical record, is not devised to make it easy for the providers to try to coordinate this care. There is a ton of time trying to sort out what's going on with the patient. And to be honest, sometimes the doctors just don't have enough time to look through all the other specialist notes. You're just focusing on your specialty. Okay, so the more doctors there are, the more medications you get, right? So every doctor has their own little like formulary of things that we like to give out. And I'm sure one of the articles that you read was from Cynthia Boyd, who talks about the number of medications that an older adult has to take if you're practicing evidence-based medicine. So if you have a heart attack, you will be on aspirin a day, you will be on a beta blocker to slow your heart rate down, you will be on a cholesterol lowering agent, and you probably have one more tacked on to drive down your blood pressure, right? So that's 4 right there from the cardiologist. Then if you have a little bit of arthritis going on, you're going to be on some pain medicines. You might be on Tylenol, you might be on a narcotic, you might have some gel that you put on your leg, and then, oh, God forbid, all those medicines from the cardiologist and the pain doctors, now you've got some GI upset. So the gastroenterologist is going to tack on a few more acid suppressant meds. So you're already at least up to 10 meds a day. And that's just 10 medicines. Some of those are twice a day, some are 3 times a day. So lots and lots of medications. Polypharmacy is a huge issue in older adults. And managing all those medications is really hard. So we've got too many diseases, we got too many doctors, too many medications, and no one's coordinating that. And what's sad is that sometimes the patients and what is really meaningful to a patient just gets kind of pushed to the wayside because we're so focused on the disease that we have to treat to meet our metrics and get paid that the issue of what is most important to the patient kind of gets lost in the shuffle. And so it is very difficult to figure out right now in our healthcare record what matters most to a patient. Okay, and for young people like you guys, it's not a big deal. But for somebody who's kind of balancing, 5 or more chronic diseases, 10 medications that you have to take throughout the day, it's really important to know what is really important for this person. The other problem with our healthcare system is that we tend to neglect the issue of mentation. How well are people thinking? And people's mental health, depression, anxiety, et cetera, all comes with older age. Not for everybody, but it does affect a lot of older adults. But this issue of, you guys know about dementia, cognitive impairment, it is under-assessed across the board in the United States. It's just under-assessed. People just blow by it. They don't think about it at all because I'm thinking about the heart or I'm thinking about the kidneys, I'm thinking about the GI tract. I'm not really thinking about how well that patient's thinking. So that gets neglected. And then we also don't pay a whole lot of attention to how patients are functioning. And so when you don't pay attention to how patients are functioning and you don't pay attention to how they're thinking, there's no way these patients can manage 10 or more medications. And so you really start to compound lots of different problems with the patient. So this is what I deal with on a daily basis. And as a geriatrician, I like to prioritize what matters most to the patient and then drive everything else after that from that basic. If they want to be at home and their arthritis in the knee is most important to them, then I'm going to focus all my attention on that. And some of this other stuff I'm going to push to the side. If they can't manage it or can't take the meds, it's okay. I'm going to prioritize what's important to them, which might be their knee pain and being at home. But not everybody thinks like that. So how many cardiologists are there in the United States? A lot. 35,000. Okay, 35,000 cardiologists who deal with the heart. It's important because it's the number one killer in the United States. But there are only 7,300 people like me as a geriatrician, okay? And 1 out of 5 people by the age of, or by the time 2030 rolls around, 1 out of 5 will be an older individual over the age of 65. So we need far more geriatricians, but there aren't because we don't get paid very well. And there are a huge number of cardiologists, and they're going to keep prescribing and prescribing and prescribing. And care will become that much more fragmented and dangerous. And so as students here, where patient safety is really important for you guys to be thinking about, you got to think about patient safety in older adults. This is where there's a lot of attention that needs to happen.
Grace, can I ask a question, or mainly I just want to get your insights.
Yeah.
So one of the first things I was thinking about when you're talking about 10 medications, 5 doctors and so on, was the need for being able to keep track of everything. And as you're aging, you know, your ability to, let's say hypothetically, go on a trip to visit your daughter and not bother to pack your statins because, right? Hypothetically. So that to me is something that sort of I feel like we're aware of and we think about, but when we think about self-advocacy or family advocacy, if someone has chest pain, it seems natural that the patient themselves wants to get seen, right?
Yes.
Not always perhaps, but I'm acknowledging and I want to recognize and deal with this, you know? If your spouse says, I'm having chest pains, you're gonna be pushing. How problematic is it that it feels like people with cognitive decline are more likely to say, no, there's nothing. Like it feels like you have the added burden of having to pull out of patients in a way that.
Oh, for sure. I mean, older patients with cognitive impairment won't come out and say, oh, I'm having crushing chest pain and it's going down my arm. They may just be confused. The very first thing is they may just not eat well, sleep well. They may say, I'm not gonna go to the football game. I'll just stay home. They may not tell you. So you have, as a geriatrician and talking to older adults, sometimes you have to really fish for what's going on with this patient. I'm looking more at function rather than I'm having crushing chest pain. I can say, this person 1 day ago was totally fine, went to the football game. The next day, they can't even like get out of the chair. Like, what's going on? Something bad's going on, and you have to fish for it. Yeah.
Well, I was also wondering about you were talking about how underdiagnosed dementia is. And like when I see that I'm bleeding, I tend to like acknowledge that I'm bleeding. Yeah. When I see that my stomach hurts, to what extent, how do you handle that issue of patients fighting against, no, I don't need to see a doctor because nothing's wrong.
And that's a tough one. There are issues of autonomy, right? There's, patients can say, I don't want to go to the doctor. I do not want to go to the hospital. You are not taking me to that emergency room, if you're bleeding out. Then the question becomes, do they understand the consequences? If you're bleeding out, do you understand that you will die? And if they can't verbalize that, then you can say, well, that patient doesn't have the capacity to make that decision. I'm sending him in 911 to get that fixed, right? But then as a family, as a caregiver, you have to weigh it, right? There's a reason why they don't want to go to the hospital. Maybe it's because they were so traumatized by the last time, they don't want to go back. So you're, as a family member, you're also having to tease out, like, do I force them to go or do I take a step back and just deal with the consequences? So not necessarily straightforward.
I have a question. Of the few people, as you said, who are lucky enough to be under the care of very few geriatricians, how does a geriatrician's care intersect, overlap, complement specialists,
Yes.
primary care providers, etc.?
It's a really good point. In some health systems, geriatricians become the primary care provider. So they quarterback and will block and tackle all the specialists who try to prescribe more and more medications and focus on what matters most to the patient and then drive care from there. In other healthcare systems, geriatricians become a specialist like all the rest of them. And then it's a matter of like, well, who do you want to listen to? You know, and the patients decide, you know, who I have the most rapport with, and often they will just go to that doctor and listen to that doctor. And quite often it's the cardiologist, right? Because the cardiologist saves the heart. And everybody knows that if you don't have a heart, you have no life, right? So you tend to listen to your cardiologist. So a lot of what's happening in medical education is that we all recognize that this silver tsunami is coming, and we're not gonna be able to train enough geriatricians because we don't make a lot of money. So we're gonna need to teach all the cardiologists how to think like a geriatrician and make sure that they prioritize things rather than just intervening all the time.
It seems even harder.
It is really hard. But there's a newer generation that's coming along that are getting it. Yeah.
Besides cardiologists and geriatrics, I also think about social workers in this context.
Important.
Yeah, and so can you explain their role and
Yeah.
how this all functions?
Really good thought. So geriatrics is not just a geriatrician. If you come to our geriatrics clinics, we have a social worker, a physician, a pharmacist, and a nurse, and a physical therapist. So it is truly interdisciplinary. We're thinking about the brain and how people are thinking. We're thinking about how they're functioning, their social determinants of health, how are they managing at home, what kind of financial things do they have going on. And so it becomes this true interdisciplinary team. And unfortunately, there are not enough social workers. There is just a lack of social workers, and they don't get paid as much, right? And so the United States is one of the unfortunate developed countries that does not emphasize or put money into social services. And so when you think about the quality of care, and you think, oh, does the United States have really good quality of care? Turns out we're not really in the top 10. In fact, we're probably in like the bottom 20 if you look internationally. And if you look at Europe, where they emphasize far more money into social services, guess what? Healthcare is a whole lot better because they focus on those areas. So it's kind of this, it's funny because we think that we're like the best of the best and we do a lot of interventions, but when you want to talk about actually quality metrics, the US is not in the top 10, sadly. So.
Don't you think that's just a normal consequence of prioritizing intervention over preventative care? Yeah.
Exactly.
So.
Yeah. Preventative care is really important, and then the social aspect drives a lot, right? When I go out to these patients' homes, it's not because they don't know that they're supposed to take their cholesterol medicine. It's because I don't have transportation to get to CVS to get that cholesterol medicine. Because my daughter works, 3 jobs and I can't get out of the house because I can't walk or I can't drive. So no one addresses that, right? And you just kind of assume that the caregivers are going to be able to manage it. And to be honest, these number of medications, we prescribe a lot, but if you actually look at the compliance rate or adherence rate in the home, it's about 50%. So if you think that you're prescribing something, they're not actually taking it. And that's why I tell people when they come to the hospital, like cut everything in half. As an intern, like when I'm teaching the residents, I'm like, don't give them the full dose of what you see in the chart because they're gonna bottom out. Like go half and then work your way up because I can guarantee you they're not taking all this stuff at home. So the 4 M's is a campaign that was actually started by my mentor in geriatrics at Yale. It's called Age-Friendly Health Systems. And so the 4 M's that drive this framework of can we create an age-friendly health system is what matters most drives everything. If you don't have a conversation with your elderly patient about what matters most to them, then shame on us. What are we doing? We're just treating disease. If you don't know what matters most, you gotta figure that out. Then you deal with medication, mentation, and mobility. Like everybody needs to start thinking that way. Not just the doctors, but the nurses, the physical therapists, the people who clean the floors and clean the rooms, like all of that. Everybody needs to reassess and redesign our care to address this. Otherwise, if we just keep treating disease by disease by disease, Medicare will collapse.
Yeah.
It is gonna be during our time that Medicare will completely collapse. All right, so what matters most should streamline care decisions, and prioritizing a patient's personal goals can guide the care team, reducing unnecessary treatments and help all providers focus on aligned outcomes. And then from there, if you know what matters most, then you say, okay, Mrs. Johnson, you've got 10 medications here. These 2 will really help your arthritis. How hard is it to take all these others? And do you understand that if you don't take these as regularly, what that means to you? It doesn't matter. You know, and you would be surprised, a lot of medications you can just chuck.
Yeah.
You don't need them. We just pile them on. We just keep adding and adding and adding. And then we never say deprescribe, like spend some time. Do you really need this? Do you really need this Prilosec, this omeprazole? Probably not. Really just doing a cognitive test on patients. So you'd be surprised. Any of us can do it. All you have to do is ask them to name 3 words, cat, penny, house, and have them recall it in like 5 minutes, and then have them draw the face of a clock and point the hands to 10:45. And if they can't point the hands to 10:45 and they can't remember the 3 words, you got a problem. They are not thinking straight, and they may have mega problems driving. They may have mega problems getting scammed by finance or people who want their money, and they're certainly not going to be able to take their medication. So you have to be really careful. But ask him to remember 3 words and draw the face of a clock to show 10:45. You'll be really, really shocked at what's going on out there. So mentation is really important to improve care coordination, focusing on mobility, just having a patient get up out of a chair, walk 3 meters, and turn around and sit back down. And if you can't do that, and if you're pushing off on the armrest, and you can't, you're doing the rock, and when you start rocking, guess what? They're gonna land right into that coffee table and slash their forehead, which is like, I think it's like 1 out of 3 people over the age of 65 have a fall. And 1 out of 10 of those is a catastrophic fall, like a head to a corner of a table, a broken hip, essentially. So just watching somebody get out of a chair and walk 9 feet and walk back will be very telling. All right. And so we need to focus on what matters, medications, thinking, your function, and then using collaborative care teams, social work, nursing, PT, OT, using this 4 M's, what matters most as a framework. And then we have to figure out how do you get that into the electronic medical record? I don't know how many of you guys have actually had to touch the medical record. Your portal, if you try to sign on to look at your own medical records or look to see when your appointments are, is actually fairly straightforward. It's not too bad. But on the provider side, it's a nightmare. The electronic medical record just has data coming at you like in all sorts of ways. This tab, that tab, this view, that view can be overwhelming. And so we need some type of a platform that is patient-centered and that everybody can look and be on the same page easily. So, what strategies could be implemented to streamline communication? This unified electronic health record It seems like a pie in the sky. I don't know, other European countries like the UK, the NHS, they have a unified system. It seems to work really well. But in the US, we decided to allow everybody to come up with their own medical record. It's pretty much dominated by Epic now. Epic has about 70%, maybe 80% of the foothold. But even with Epic, is this recorded? Is the head of Epic in the hurry here? That's probably.
We can,
That's okay.
so,
Judy, I'm not saying anything about Epic, okay?
we will either not post or we will redact before we post.
That's fine.
Other.
Epic has a lot of patient safety systems in place. It's actually not that bad of a system in terms of safety. It can double check you on things. But when it comes to big picture things, it hasn't really taken hold. Like, how do we make sure that everybody's on the same page? That being said, there are committees at Epic that look at this type of work to say, okay, how can we streamline things? How can we unify it better? And to be honest, nationwide, there's a health information exchange that we try to get the key pieces of things to be able to convert from one health system to a next health, like the medication list. Probably pretty important to be able to convert from one system to another. Allergies, pretty important. But day-to-day documentation, like real-time documentation, it's really difficult to figure out what's going on. Interdisciplinary care teams are really important. Pharmacy reconciliation, our pharmacists are very, very important to help for de-prescribing. Coordination of meetings. Virtually, the rate of growth of virtual visits has skyrocketed in the last 4 years because of COVID. No one really understands whether these virtual visits are actually effective or not. I think it serves a role, but not probably everything. Remote patient monitoring, I'm involved quite a bit with this, where we check people's blood pressure, heart rate once a day. We check in with patients in terms of how they're feeling. And we can actually save a lot of readmissions because we jump ahead. We are forward thinking. We're like anticipating something's bad's about to happen to this patient when their blood pressure is getting a little low or their heart rate's starting to creep up. We actually act on things. And so that could be the wave of the future in terms of keeping patients out. But this integrated care dashboard, if you guys could design something like that, you'd make a lot of money and it would help a lot of people. I'll give you an example. We had this older woman who was in her 80s who lived in Atlanta but decided to come visit her kids here in Michigan, and she had a bad stroke, which left her not able to speak really well. It was like word salad, and she was weak on one side and had to move in with her daughter here. And there was no hope of her going back to Atlanta because she really needed a lot more assistance. So the doctor down in Atlanta didn't have an electronic medical record that fed into Epic. And then we were like trying to figure out what the heck is going on with this patient. Her blood pressure is super high and then super low, and she's having all this pain, and multiple specialists are starting to get involved. You got a pain specialist, you got a cardiologist, you have a neurologist for the stroke. And her electronic medical record is a disaster, and it will harm her because nobody knows what is going on and who did what the day before. And now she's coming to see this doctor. You can't figure out what that doctor prescribed. And so we're just all on different pages. And this is not atypical. And luckily she has a son who's a doctor, a radiologist, who tries to quarterback things. But if you're not in healthcare, it is impossible to quarterback, and you just don't know what harm there is. So this integrated care dashboard where everybody can be on the same page, what matters most to this patient, and drive care from there, and know what their mentation is, know what their functional status is going to be really important. So hopefully Epic someday will be able to help with that. So I think we're getting to the brainstorming part here, right? So this is
Time to solve all of the problems before some of us are in desperate need of those solutions. And
I
it's
expect you guys to fix the system before I need it and for my own care. So what are the key questions that healthcare care systems should consider when applying the 4 M's, what matters most, mentation, medications, mobility, to improve geriatric coordination. How can we ensure that what matters to the patient guides every aspect of the care plan? What strategies can we put into place to reduce polypharmacy? How can we better integrate these cognitive health into just routine assessment? Look how easy it is, right? Look how easy it is to say, I mean, why couldn't they do that on the portal? Draw me a face of a clock and just upload it, please. Just 10:45, upload it onto your portal. Can you remember 3 words? That's all I need you to do. Take a picture, take a video of me walking 9 feet from your chair at home up to the TV and back. Let me see how you do. We don't do any of that. And how easy is it to do it with our phones nowadays, right? All these things can be easily incorporated into the electronic medical record. What tools can support continuous monitoring? These blood pressure cuffs, when COVID happened, we all had O2 sat monitors. Everybody has one of those. You can get a CVS for $25, right? Why aren't we monitoring this for patients with cardiovascular disease or lung issues, respiratory issues? And why isn't that just running in the background? And why can't computer systems figure out, oh, alert, this person's oxygen level just went down, or whoa, their heart rate went down. We all wear Apple Watches. The Apple Watches are keeping track of our heart rates. It can keep track of patients' steps. I can tell somebody's step, they're at 20,000, now down to 10, now down to 5. Oh, they're not walking at all. Why isn't that an alarm, right? Instead, we wait for the patient to call in to say, oh, I fell and I can't walk. But we have so much technology out there on our phones, on our watches, that it can get into the record and really help us kind of anticipate what's going on with patients. What systems will improve communication between the specialists? Why do I have to sort through each note? Okay, Mrs. Jones went to see the cardiologist yesterday, and then 2 weeks ago went to see the nephrologist, and oh my God, I've got another patient I gotta go see in 15 minutes. I don't have time to read over this. I'll just ask the patient. They don't know what's going on. So, I spend a ton of time trying to figure out the communication between the specialists. How do we make it more accessible to patients and families? How do we measure the success of this, and what other resources would be needed to implement the 4 M's if we needed to do this? So I think that's it, right? Yep, that's it. So big problem, humongous problem, and you guys may be just too young to see the electronic medical record. You should go look at it. Do they get a chance to play with my chart? They should all play with my chart.
I don't know if you can handle my chart. I hear, Jack Nicholson's voice, who can handle the health record. Go ahead.
I've seen enough in my chart already. I'm good. So I hate to be the guy, but the easy solution to a lot of these problems is nationalizing the healthcare system in this country.
It's not gonna happen.
Crazy.
Yeah, crazy.
Crazy, that would help. So my experience is mostly in pathology and allied health and oncology stuff.
Yeah.
I'm curious, I think I know why, but why are we not using interdisciplinary care teams to the level that they should be? Because at least in pathology, it's the thing to do. Not only do you have interdisciplinary care teams, you also have, oh, I don't know about this case. I'm gonna go knock on Dr. Steve's door. And the consults happen all the time because they're all just sitting right there. That's hard to do, but they get around it, at least where I worked. You have interdisciplinary care teams at least once a week where you talk over your patients before they go into surgery or whatever with the oncologist. You talk with surgical team, you talk with radiologists, everybody talks about the findings. And it's really helpful for this kind of stuff, complex patients. Shocking that geriatrics don't have any kind of incentive to do that. That seems like an easy way to.
That's a really good question. Are there incentives in place to make sure you have an entire team, a social worker, a nurse, PT, a physician, pharmacist together? There are some incentives, but they're meager in terms of how much you can make, and you have to document it. And you have to do all this big billing, and it's too painful to do it.
I feel like there's a
Because
way.
doctors do this, we type. We spend all of our day, my kids just thinks that I'm just on the computer all the time, because all I do is type all day long. And, now we're getting to voice recognition to be able to do our notes, which is a little bit better. And soon it'll be able to be like, I think it's called ambient. Yeah, where they're just gonna be recording what's going on in the doctor's office, and it'll be able to just spit out the note. When that happens, then we really can focus on interdisciplinary teams and these 4 M's. But you can't do it right now, just the way that we're all like,
Has anyone gotten their big brain hat on and like tried to reach out to Blue Cross and be like, hey, we could save you money if you incentivize these interdisciplinary care teams that might.
I'm texting with Amy Cho right now.
Amy.
Speaking of, but the notion of moving towards value-based care as opposed to fee-for-service, so everybody, unfamiliar term for anybody? We talk about value-based care, thank you for raising your hand. So value-based care, in the simplest way that I understand it, which is not a perfect understanding, is what you think it should be, which is I get paid a certain amount of money basically to keep you healthy, as opposed to I get paid a certain amount to take care of what is wrong with you, because our incentives are different. Right.
Completely bored.
So maybe what we could do for a moment is, I also know that we haven't given all of you always a good chance to get to express ideas, and maybe we could just do, I'll take some notes for you, Grace. We don't have to answer even the questions, but part of what I'm hearing, you remember 2 times ago, we were talking about mental health and adolescents in the emergency department. And we started sort of breaking it down into, we could think about ways to help mental health issues before they arrive, prevent them from coming. We could think about ways to manage their care while they're in the emergency. How could we just break this down a little bit in terms of not what is even the solution, but, and I'm gonna talk for a few more minutes to stall for you to have a little bit of time to think, and we'll go this way and around. But for example, it seems like connecting family members. Right, the idea of having advocates or having better family or other family in a non-blunt sense. Go ahead, Kemi.
Okay, 2 questions. 1, can you go a slide back so the questions are on the board again? And then 2, I don't have a healthcare background, so I'm a little confused. So my question is, can you clarify the transition into geriatric? So like, I'm 64, I turned 65, do I get a whole new care team? How does that work? Like, do I just get one as issues arise?
Exactly. So everybody has, well, not everybody, but most people have healthcare insurance, right? And what happens is, like, when you're 26, you finally come off your parents' healthcare insurance, and maybe you're gonna go see your own doctor. You don't need a pediatrician anymore, right? So now all of a sudden you're an adult and you get a doctor, and you get a primary care doctor. And that primary care doctor should be, dealing with preventative, your vaccines, and making sure that you're not developing diabetes or high blood pressure, things like that, preventative. And then as you age, then you start to be like, oh, I've got this pain, I've got, my lungs hurt, or something's bad. And then you go see a specialist that the primary care doctor will write an order, say, go see a lung doctor. So then you end up with a lung doctor, and then you end up with a orthopedic surgeon to help your knee, like you got some arthritis and knee replacement. And so you go from 25 to 30 to 40, 50, and then you hit 65, nothing actually happens, except that you will probably be on Medicare. So your insurance is gonna flip over to Medicare, but you usually can still see your same doctors that you have been seeing. And then if you happen to be in a healthcare system where there's a geriatrician, maybe if things are starting to get really complex and the families are really confused about what's going on with all these doctors, then they'll refer you to a geriatrician. Otherwise, you'll never see a geriatrician if you don't have a geriatrician in your healthcare system. So, but you, as anybody kind of, you know, if you're just out in the middle of Texas or whatever, you'll just have a primary care provider and then start adding on more specialists one by one, depending on what ails you.
So I'm just gonna throw into our list of possible problems, challenges to solve is, given that very small number, I hope this wasn't yours, but if it was your idea, then you can say it was your idea and you get a pass. But given the small number of geriatricians, making sure that they are being matched up with the patients who are most desperately in need.
I don't need to be involved in patients who are really healthy, right? But the ones that are really complex, where I need to help prioritize things, sort things out, then you probably do need a geriatrician.
How do you interact with the PC?
The primary care provider? Yeah, so I would just send them my note. This is what I recommend, this is my assessment of their cognition and their function and what matters most to them. And I would just send them a note and hope that they take the recommendations. Which is like, 20-30% of the time.
So let's start with an idea. What is something you think we could try to make better?
For the communication between healthcare providers, we may use, you said that sometimes doctors don't have the time to read the notes and all the stuff. We may use AI, for example, to just read out all the medications that the patient is taking, what other doctors recommend to them, so that they can hear and know the the primary things before the meeting.
So getting providers more effectively to learn what happened. Julie, you look.
Well, I was thinking, even though I'm late, so I've missed the presentation, but I get the gist. But a trigger for a geriatrician, because there's nothing that connects a patient or their family to a geriatrician, and unless you have some knowledge or prior experience, you would have no idea. I just have had elderly parents who had very complex multi-disciplinary care needs, and no one ever mentioned a geriatrician. And I happened to talk to a friend and she's like, you should get a geriatrician. I'm like, what?
What's
But
that?
then it wasn't even clear how to connect to one.
Right.
And they were seeing all kinds of doctors all over the place. And so it was very, very the access to it. So is there a trigger, so many conditions, so many doctors, so many visits within a time period.
Right.
But some threshold over which a patient then triggers a referral or some kind of access to that care.
Does that not depend on the physician, right?
Which
The
one?
primary care, right?
But it would be
'Cause
more
when
than
they're-
it's which one, right? You're seeing a cardiologist, you're seeing an oncologist, you're seeing you name it.
Yeah.
And then
And they think that
They all think
each
they're right,
person
yeah.
thinks I'm the
they're
one
thinking
running
about the
show.
part of the
Part
body
of the
that they're
organ
focused on, right? Their organ. And so who's looking, even during hospitalizations, you're not getting referred to one because you're focused. So I think some
No, a
trigger.
trigger would be good. We don't have something like that.
I have a suggestion. The pharmacist can look at the number of prescribing physicians. It's not just how many different medications you have, but how many different people prescribe them to you. And that could by itself
Be a trigger right there. Number of medications and number of specialists, yeah.
So I'm gonna spend a little bit more time just getting some, as we're moving into trying to solve, what are the things we wanna solve? Nick, what have you got to add to the list?
I was thinking about having more community outreach programs to teach people about geriatricians and teach people about hey, here are things that you can be thinking about and asking your doctors if okay, I'm taking these other medications, or even can you talk to this other person and say this person just prescribed me these medications, will they conflict? Just I didn't know about any of this stuff coming into today, so I'm sure many people in the community don't know about these things and are just trusting that their doctors are communicating like they're not. And so having like workshops with them to teach people about their own care.
Okay, so we've talked about the importance of being aware and getting access to a geriatrician if appropriate. We've talked about the importance of having different doctors communicating with each other. We've talked about the communication between the family and the providers. Between the three of you, I'll give you a group. What besides those, right, if we could fix the communication with the families, if we could fix, would everything be solved, or are there still things that we would need to fix? Are there still problems that maybe we could make inroads on?
I was thinking about the getting like what matters to the patient clear like early on. So when I think we were talking to Kemi about when the transition happens from when you're like a, I guess, adult patient to a geriatric patient, in my 50s or 60s when you do start having like that random pain or like diabetes or whatever, like your primary care doctor could start that conversation before referring you to specialists. Like you are having this illness, but like there's other things going on, what do you want to focus on?
Yeah.
And then that could manage the being referred to a lot of people, getting a lot of opinions and getting a lot of like medication, like all of that.
Anything you wanna add?
I was gonna ask more of a question, I guess.
Go for it.
So is there a specific reason why the like primary care doctor isn't managing that? Cause if they're sending you to that person, shouldn't they know the outcome?
Yeah, they should.
How many cases does a PCP have though?
Yeah.
A day?
That's the problem, is that the primary care providers are typically seeing 20 to 25 patients a day. It's usually 12 in the morning, 12 in the afternoon. So, and they're used to preventative medicine where they really are just, making sure that your, diabetes and hypertension are well under control. But when you, but there are primary care providers who do a good job, or they really do try, right? They do try, but not everybody is like that. And they don't, primary care still doesn't have the tools of like thinking about cognition. They just don't think about cognition as their first and foremost priority, right? So we have to almost like make it systematic that everybody over the age 65, we just do this universally. We're gonna start testing your cognition, we're gonna test how you drive, we're gonna test how you get up out of a chair and walk. Like we should be doing that. If we did that, just regular assessments and made it really easy for the primary care provider, we would uncover a lot of stuff.
I wanna
But they
make
just
sure
don't
we
do
get
it.
to the folks in the back and then I'll
Yeah.
come back to the front with you.
Yeah, finish it. That's it. George?
I guess like you said the volume of geriatricians is low, like is there, I don't know, low hanging fruit solutions like getting more of them? I don't know.
Well, you'd have to pay us like triple amount, maybe triple, quadruple the amount, like pay us like a cardiologist.
Yeah, that gets to, I'm a fellow geriatrician with Dr. Jenq, and that the big problem with recruitment right now is that it's not a popular specialty. Typically seats don't fill. It's one of the 3 specialties least likely to fill in the match process in terms of residency and fellowship matches. And I think the complexity of the patients plus pay is a big part of that, unfortunately. So there would need to be better financial incentives for people to become geriatricians. In other countries, actually, primary care doctors and geriatricians are paid more than certain specialists like anesthesiologists and sometimes surgeons. So that's why it's a lot more popular in Europe and stuff like that, just because the incentives are different.
In the US are trying to shake that up. Like there are medical schools now that are endowed that you do not have to pay for medical school. Because you come, yeah, I know. Because you come out of, if you go to medical school and you have to pay for it yourself, you come out with like, $400,000 in debt, right? And so guess what? You're gonna become a cardiologist because you have to figure out how to pay it off. So the incentives are all wrong, right? So we we incentivize people at the very beginning to become cardiologists, but slowly, there are a few medical schools, I think maybe like 10 medical schools around the US that are paying for people
It's at
to,
least 5 right now, yeah.
at least 5, right? Yeah. What you got?
I keep on thinking about telehealth in this scenario, and so we've seen the rise of it, right? And elderly people feel more comfortable at home, they don't wanna move.
Yep.
But I think a con that comes with that is that they don't necessarily feel comfortable with technology.
Yes.
But they don't wanna go to 5 different doctors in all around town.
Yeah.
So if elderly people, it goes to the community resources, if for example, hospitals set up collaborations with libraries that could help them, sometimes libraries let you rent out a room and on the computer and they can be the ones to set it up and they're happy to do that. So I think that would make things easier and streamline some things, but there are pros and cons, but
You'd be surprised, there are a lot of folks who do not have internet access, and Somi is actually doing some work on that, looking at telehealth access, not straightforward, especially in Michigan, there's a lot of rural parts of Michigan.
Yeah.
You wanna jump in real quick, Irvi, and then we'll finish the back?
Telehealth conversation, if there's like issues with communication of all these 5 different specialists you're seeing, you could have all of them be with the patient at the same time with this telehealth.
Wouldn't that be great?
Yeah. And again, they don't have to, go in
So
person.
right now, if you try to get onto your portal and you want to, let's say you have 5 doctors, but you just have one question, you wanna ask all 5 of them, you can't do it. You have to individually message each doctor and then try to coordinate all their responses. There's no way right now, as a family member to say, hey, everybody, let's do an interdisciplinary conference, in pathology, everybody, cardiologists, nephrologists, rheumatologists, primary care provider. What's important? What are we doing today with this patient? What you got?
So I actually want to ask a question. I don't have any healthcare background or I have not even gone to a hospital in the United States. So what exactly is a geriatrician? Is that a consultant for the older people?
Yes.
But do you guys provide care for them?
So we can be a primary care physician. Some people do have a primary care geriatrician and maybe I think they talked earlier about the fact that more complex patients over 65 may switch their primary care to geriatricians. Otherwise, they can have somebody else as a primary care doctor and then we can be a consultant for cognitive impairment or frailty, some of the specific things that affect older adults that are maybe more high risk of disease.
It's in this process, maybe just what matters is the most important thing probably. Cause my grandma, she used to have diabetes, but at the same time she need to do a surgery. So which means because the diabetes, she doesn't have the ability to heal herself too quickly, like a regular person.
Right.
And so the doctor, they will came to us and ask us about what you guys think about, cause she's pretty old, she might get a chance not to really heal herself after this surgery. Yeah, so I just feel what matters really matters a lot.
Yeah, and where was your grandmother?
In China.
In China, right? So that surgeon actually asked the right thing. Before I go take your grandmother's foot off, what's important to her, right? In the United States, because we're fee for service, they're in the back of the surgeon's mind is I'll get paid to get that surgery. So it's just in the back of people's minds, and that's the way our healthcare is set up, is that they're more likely to take the foot off. Actually, what they do is they take toe by toe by toe off and make it even more difficult for an older person to walk. If you actually amputate below the knee for diabetes, you can actually walk again because you get a prosthetic, you heal fast and you can start walking. But in our United States, what we do is we just take one toe off and 6 months later we'll take another toe off and then you can't walk for years and years and then they don't walk in the end. So it's a very strange system that we have here in terms of how physicians get paid fee for service and then what's important to a patient and what we can really do in a value-based system.
So thank you for coming. Were you on your phone? I saw someone say, I was like, I know this name.
I had a meeting on Central Campus and then I was trying to listen in while I drove up here.
So you've sort of heard where we're going.
Yeah.
Do you want an insight to add to our list that we can?
No, I think you actually brought up a great point. So something I always like to teach, I'm an inpatient geriatrician, primarily work in the hospital treating older adults, and frailty is something we look into. And frailty is exactly what you described as the inability for somebody to really bounce back after a surgery or after a hospitalization or something like that. And I think it's important to point out that we need to see and ask ourselves, is this person really going to get back to a previous level of function? You know, we've unfortunately seen several cases in the hospital, more than I'd like, where a person gets an unnecessary procedure such as like an aortic valve replacement or something like that, because aortic valve stenosis is very common in older adults. But nobody really thinks about the fact that the person wasn't able to walk and was bedbound to begin with. So is this aortic valve replacement really going to help them walk again? No. The person, a couple of people who've seen that surgery never really had any improvement in their level of function after the surgery. So, what was really the point? And so, and I think having those conversations, even if they're challenging, sometimes the families are not ready to have the conversation of, maybe just looking more at a hospice trajectory or something like that. But I think that's important to, kind of introduce those concepts early so that, families can maybe adjust to that, and that we use the resources for procedures for people who we think will actually get the most benefit from them. And so I think it's, we look at a few things called patient autonomy, justice, beneficent and non-maleficent. So the idea is we want to honor patient autonomy, but we also want to make sure we're providing benefit to the patient. And so those are some of the core values in medicine that you guys would learn if you went to medical school. And so I think balancing those is hard, and especially hard in geriatrics, because what the patient wants should be primary, but we also want to give them all of the possible information they need to know about how well they'll do, after a hospitalization or a procedure or something like that. So.
What you got?
Yeah, so the first thing that popped up was like self-monitoring tools, especially like giving patients variables that gives data to the healthcare providers. The other aspect I thought about now is like the mental health aspect of it as well, because usually when patients that lose are more dependable on others, they lose a sense of purpose. How do you sort of deal with that, especially because I know that mental health services often is quite hard to get access to, especially if you live in rural areas, and especially for senior patients, like elderly patients who are not as tech savvy. How do you sort of go about that approach as well? Because I think if you give them a sense of approach, like in the long-term care that I volunteered at, we would often bring people, like that could be animals or kids, just to interact with the patients, or elderly patients, and that sort of brought change in their day-to-day activities. I know that's kind of hard for if you are not living in a long-term care facility. How do you sort of bring that, I guess, environment or just idea in your patient's mind, sort of interacting outside world a little bit?
That's a tough one. Long-term care facilities are, they have cropped up in the United States out of convenience, right? Because the family unit is not as robust to be able to take care of an older patient in their home. And there are some examples of that, but in the United States, you tend to see a lot more long-term care facilities than in other countries where people just take care of their older ones, in the family and can have all those type of interactions and feel valued, right, within the family as opposed to being by themselves. But it's tough. They have different type of programs out there for frail elderly patients. The program for all-inclusive care for the elderly is one of them, PACE, where the state will actually pay for these patients to go to like a center. They'll transport you to the center, like a senior center, and they'll have activities and interactions, etc. And then at night you go home and you be with your family, because that's when people are at home and then your kids can go to work. So it's hard though, but that type of interaction is important.
My grandparents, what my parents did was they sort of got them into like daycare, like day daycare, and that sort of brought a lot of change in their
health outcomes as well.
Okay.
That's why I asked that question because it was suggested to us by someone of parents.
Yep.
So
How does that work? Did it work out okay?
much better than expected. I think it just like gives them a sense of motivation to like do something. And it's nothing what happens when you're alone at home. You get very bored and at that point
Social
it's just
isolation is the worst. It affects everything. It affects your mood, it affects your eating patterns, how much you walk around, and people who are socially isolated do far worse than if you're married or living with a family member.
Yeah, and for PACE programs are a lot like what you described with adult daycare. They actually have a primary or care physician in-house who's like the PACE medical director. They might have a podiatrist, they may have a mental health provider, some do, some have like psychiatrists on site. And the only thing is, it requires dual eligibility with Medicare and Medicaid. So unfortunately, it kind of gets to an insurance issue. If somebody is not low-income senior who has both Medicare and Medicaid, they don't qualify, so that can be a challenge.
Yeah, so I think I can also relate to how you said about your grandma. Same thing with me. My grandma's 92 years old and she doesn't speak English and she hates the doctor, hates going up. She has on so many medications, she goes to so many specialists. And she's lucky enough to have, well, she used to have a lot more of her kids around to be able to take her from specialist to specialist and be able to converse with the doctor, let her know what's going on, and it's a lot easier. But she doesn't have as many kids around, so it's really just reliant on like my dad and my mom to take her a lot. But in general, I think this is a very common thing amongst like immigrant, elderly, either women or men. They're not able to really relate to the physician in any way, or they're not able to have, I guess, their perspective, or just have the doctor think through their perspective because they just simply don't know what that perspective is. And so I know like some of the mitigations for that would be like translational services and things like that. But even then, like there's still some gap to be made, to be resolved. So I just think maybe if there's some kind of, and maybe just like for example, like cities that might have a high population of certain demographics. For example, Detroit, there's a lot of Middle Eastern people. I'm sure there's also different areas with specific populations of demographics. So maybe if there's any like training at hospitals for like different cultural differences between elderly people, I think one that'll help build better trust between the patients, elderly patients, and then also the doctor. And it'll help the doctor be able to understand their life choices that they make, and also take into account what's important for them, kind of going off of, what matters.
Yeah, what matters most.
Yeah, so I think that's definitely something in America with so many different backgrorounds. That's one thing you're not really trained on in medical school, you're just so focused on the science of it.
Right.
And that's like, I mean, rightfully so, but that social aspect too, I know like is very important when you are providing care.
Yep. Very, very important. Understanding people's culture, the background of where they come from, the family is so important. And medical school, there's more and more training about cultural sensitivity, but you can't remember everybody, all, and it doesn't necessarily mean that if you're Korean, you're gonna abide by 90% of what Koreans believe in, right? You could still be the 10% that think differently. So it all gets back to just what matters most to you, right? If you just ask that, it should be culturally sensitive.
I think another important consideration, maybe it falls more into the telehealth side of things, specifically when it comes to reimbursement models. There's so much potential right now for virtual care. However, the incentives behind it and what to do about, okay, so if we were to go down the route of more virtual care, understanding the insurance implications of that, just because that's not really drawn out yet too much. For instance, over the summer, I was working with a healthcare consulting firm, and the academic medical center that I was consulting for wanted to increase their virtual care platform, but a lot of the barriers to that revolved around reimbursement. And the interesting thing is this academic medical center happened to have a really robust infrastructure because of COVID,
And because they built it out so well for COVID, a lot of the other health systems in the area that didn't build it out so robustly kind of fell behind in that area, so they were able to capture a lot of market with that. And so they saw that as being a really viable solution to being able to reach new patients in this hybrid model. But again, one of the barriers was that, because that policy had not really caught up with the technology, that was kind of preventing them to be able to see a lot of patients, because they were like, well, we can have more patients, but like, what are we supposed to do with them now when it comes to the billing cycle, or if they have to come in for a procedure, how does that build?
Yeah,
So
you definitely don't get it to bill as much with a virtual. You can see a lot of people, but you can't bill, and so the balance is, healthcare system, but if I can't bring any money, why am I doing this?
So this was discussed a little bit earlier, like big picture thinking. We talked about how a lot of the other advanced countries, specifically in Europe, spend a lot more on social spending. And if we look at the needle here between like healthcare costs, like reimbursement and social spending, it's like outrageously biased towards spending. That needle needs to be more equitable, and theoretically that could solve a lot of different upstream issues. Number one, we discussed that there's not a lot of geriatricians at all, and that's largely because of the way our reimbursement model is. There's no incentive to go into a department that your hospital's gonna be losing money on, and they're not going to want to expand your services. But if we have more social spending, and maybe Medicare or Medicaid are actually like reimbursing more, then a hospital is gonna be looking at, maybe we can expand primary care or geriatrics and not lose money on doing something like that. Also, when you have better social spending, prevention and primary care throughout the entirety of your life theoretically should be better, at least access and your outcomes should be better, so the point when you get to that geriatric level of care, you are going to be a complex case, but it theoretically should be a little bit less complex than it is now. And then also with that system, I'm in another class right now, and a few of us are, it's health data class and health data management. And we talked about how data silos right now, if you're seeing 5 different providers, also not even maybe at the same hospital, and that might be at other hospitals, the way that they're not communicating, or you mentioned earlier, you wanna send a message to the entire team. It's not very feasible, but some national EHR does need to be created, or some form of health information exchange, because patients can use it that way, and then also doctors can be constantly in the know of everything that's going on. So I know that the national health system is, I think, inevitable in this country, but probably not for a very long time, but we need to move.
Where can I die?
What'd you say?
Nothing.
So as we get close, I want to just highlight a couple of things, and then I also want to propose, and maybe George and Rainey, you can help me think about possibly coming back to this for another one of our sessions, just to start digging into some of these topics, or that may be one of our asynchronous classes, because part of what I wanted to try and capture here is jumping in to solve the problem, we need to step back first. And so some of the problem is what leads to people having these conditions, right? The issue of, did you have a good diet through until your older age? Some of this is the communication piece. Some of this is the family dynamics piece. I think this is probably, for me, the most exciting thing to think about, like, what are the mechanisms, do you really need to do a Mohs procedure on someone who's 96? Like, do we really need to put someone through a lot of pain for reducing the risk that in 5 years they'll get skin cancer? So, think even this one thing about doing what matters. How do we understand the trade-offs? How do we communicate? How do we handle the fact that you sometimes have an elderly patient who says, I'm good. I don't want to spend the rest of my time going to doctors. I want to just kind of do my thing, and something's going to get me. Yeah. And an adult child saying, no, but we should be taking you, we could. And let's add in the layer that maybe the older patient doesn't have the ability to recognize it. Yeah, but if you took the medicine, you actually could go fishing more or whatever. So even this alone, I think, gives us really interesting questions to explore. But I just wanted to highlight one other thing before I hand off to Dr. Jenq to kind of close us down, which is this idea that in the same way that we need interprofessional teams caring for our patients, we need interprofessional teams solving our problems. And so for those of us who are industrial engineers, I immediately gravitate to things like the transportation component, right? How do we coordinate being able to do, like, what would it mean to schedule team visits where the oncologist, the cardiologist, nephrologist all were available at the same time? Have you ever tried to schedule a team meeting with other students? So there are lots of things that as industrial engineers we could do. But this notion of cost benefit analysis, right? Sometimes we do something, I think about the times that we say it would cost a fortune to have a nurse in the family's home. And when somehow we miss the fact that not as big a fortune is the opportunity cost of a stay overnight. You know, this idea of sociology and what are the family dynamics and what are the components that make up, how do we think about why people do and don't have their elderly relatives living at home and what are the cultural components, the policy issues for those of you who are in public health or public policy, how do we think about at some point the tip may happen where people realize that yes, we're spending whatever percent of our income on taxes in Sweden, but then we're not spending what you're spending in the US on healthcare because we're preventative rather than post. There are some huge ethics questions here. And I think those ethical questions are gonna get more and more complicated as we have this top-heavy kind of issue. The economic components. So I just want to encourage you to think about, as you're getting interested in some of these problems, thinking about who are the people that you would want around you to be able to say, I've got this great technology idea that I'm a device person and I'm going to build a device to enable us to predict the fall before it happens. Okay, now can you help me figure out how to do the cost analysis to justify to Medicare and Medicaid that it's a savings for them to pay for the device rather than the hospitalization? And can you help me with how we take a certain cultural group that's going to be reticent to use this, or how do we deal with the older person who says, but I'm not gonna fall, I don't need it. Think about who you can partner with to be able to get these things to work effectively. So we've got about 5 minutes. How would you like to encourage us to move forward? What do you feel like is the low-hanging fruit of, if you could only do one thing, you could say, you guys are gonna fix one of these problems and it can't be national health care because that's not gonna happen.
No, I think if you could get to figuring out how to capture what matters most to a patient, that drives everything. If you can do that, you will solve the downstream effects of focusing what's really important for the patient, will solve a lot of the problems.
Yeah, I think like when you're figuring out what matters to the patient, why don't we, there's no current like standardized questionnaire or test, because I know we have the ones for like anxiety and depression. So if we had something like that where if someone did a study, interviewed how many hundred of old people and then put them in like major categories, if you just, when you're waiting for a nurse or the doctor the next time, slide them a note, slide them the little sheet saying, oh, your first value is your physical mobility, your second value is your staying at home. And you could really just have them rank it 1 to 2. And then you can also include, like the last question is, draw that clock that you mentioned. So if you standardize it across everywhere, you can say like, oh, this was my value score for my last exam. And you can put that on your chart and now everyone knows, okay, I'd rather be at home no matter what.
Yep.
So just like a standardization across that was my first idea.
And I want to note, as we wrap up, that we did have a great comment on the chat. Evidently, there's a PACE which is predominantly attended by Chinese in San Francisco, and it was started by Chinese immigrants. So thank you. I couldn't see who that was coming from, but thank you for sharing that.
Yeah, ACE was started in San Francisco, Huge money saver for the healthcare system there,
Just as we're talking about concrete things, at least when I was in med school, they taught certain vitals get collected on a patient visit for reimbursement's sake. Telehealth is new. Telehealth is a new field. We're trying to, well, at least the people who pay the bills really like it because it's cheap. Why has nobody thought about putting in a reimbursement as a vital, one of those videos of a gait assessment? You know, something like, because you talked about how important that is, it seems like Airball.
figuring out who to talk to in Medicare, figuring out who to talk to at Blue Cross Blue Shield about saying, this is so important. Do you know, Blue Cross Blue Shield, how much money you spend on emergency room visits and hip fractures each year? Like, if you just built this in and said,
It's an easy sell.
yeah, you just have to videotape somebody walking, get out of a chair, walk 9 feet, walk back, draw a clock, and we'll reimburse you right there.
I mean, it's
Boom,
easier than
$100 right there.
Yeah, that's way easier than trying to get blood pressure remotely, you know? So.
All right, everyone, you wanna, last word?
I'm just curious, so based on your experience, what are the reasons like why older people they don't want to take their medicine? Cause I noticed that is kind of like a common things that happens not just for older people but also for young people with other disease. Cause I have a friend, she's having some mental issue and she will show up every week to her mental physician but never took the prescription. But she will take the medicine to home but
If you
never
haven't
take.
taken any medications yet, you're lucky. Once you start taking them, you realize that there are side effects. And they compound. One medication causes side effects and then you take another medication to counteract that one. And that's this whole issue of cascading polypharmacy. You end up taking more and more. And they make you, some of these medicines that save your heart actually make you feel kind of bad. Like beta blockers, which is known to decrease mortality. It saves your life from a heart attack. Actually makes you feel like crap.
And I'll add, when I was a geriatric fellow, we actually had all the residents actually take a pill box and put candy in it, like 10 pieces of candy in each pill box, like Sunday, Monday, Tuesday. And we tried to see how many of these 20-something, resident physicians were able to actually get through the whole week. And most of them, including me as a fellow, only lasted 2 or 3 days. A lot of these patients are on 20 meds. They may have cognitive impairment. It's very difficult for them to keep up with it. Even somebody who's cognitively intact, it's hard to keep up with all these meds. Yeah.
People don't, in general, people don't take, the compliance rate is really about 50%. Any of you take medications? How often do you take it perfectly? Everyone's like, because it's
What was
impossible.
that? Before we start publicly shaming some of us, thank you again. Yeah.
Can I have a publicly shaming question? And I'm gonna ask it, but you might not be able to answer. So election's coming up, Washington County, Prop 3.
What is Prop 3?
You're gonna have to.
It's a millage to establish some fund for senior care, something.
That's terrible. I did not know about that. Do you know about
I
this,
knew
Soumya?
about it, yeah, my parents just got their absentee ballots, they live in the area, so basically it's to allow increased services for like Meals on Wheels, like Ann Arbor Senior Center, things like that, so it shouldn't affect you guys too much because you're students, you're not paying taxes, not most of you, but yeah, for the rest of us, it's a very minimal increase in the taxes, but it significantly increases the resources available for our seniors, so try to vote yes if you do pay taxes in Ann Arbor. Yeah.
See, how sad is that I didn't even know that was I thought Prop 3 was something else. See, these type of issues don't get to the forefront, right? If everybody knew, Prop 3, that's what it stood for, and it's Meals on Wheels and it's more senior, yeah.
Yeah, there's a lot of things about like use of real estate and stuff in Ann Arbor that is getting all the public attention, but nobody cares about seniors, unfortunately, in the public realm. So yeah, no, but I would advocate voting for it. A lot of people kind of skip up all the proposals in the ballots, but if you guys can take a quick look at the proposals when you're voting.
Flip the page.
Yeah, flip the page, exactly.
Let's all thank Dr. Jenq
We'll come back to this topic.
This is gonna be the next decade, so this is a person's career.